Hello, everybody, and welcome to this conversation with Jacaranda Health. It is the holiday season for all of us, so happy holidays, everybody. We have two wonderful guests with us today. I am Veena Khanke, Director of Grants and Partnerships at Dining for Women, and my guests are joining us from Nairobi, Kenya. First, I have Jane Kageha, who is a nurse mentor. Hi, Jane.
Hey.
Then we also have Dr. Sarah Little, who is an obstetrician and gynecologist, and she is the clinical lead on this project. So we have been chatting for a little while, and Sarah, Jane, why don't you go ahead and share your presentation with us?
Great. So thank you so much for giving us this chance. We at Jacaranda, we are so much excited. We're going to share a lot with you so that you can understand more about what we do.
Great. So just as a little bit of background about our project, we know in developing contexts that there are two main healthcare challenges. That would be access to care and quality of care. So access of care in Kenya is actually really improving. There has been a huge initiative for universal healthcare coverage, especially for moms and babies. We know that 60% of women now actually do deliver, and that number is increasing all the time, but do deliver in healthcare facilities, and that 90 to 95% of the women that deliver in healthcare facilities are delivered by a skilled provider. We have chosen to focus on the quality of care piece. So we also know that when women do go to healthcare facilities, they don't necessarily receive the best quality. So there's been a lot of initiative with NGOs and other organizations to try and promote emergency obstetric training and training for complications in labor for nurses. And consistently, we found that even after nurses have gone through this kind of training, that they score less than 50% on skills examinations, and that 9 out of 10 babies and moms that die in healthcare facilities are related to poor quality. Because of that, we came up with an idea in 2017 to focus on nurse mentorship. So as opposed to doing these mini trainings that usually last a day or maybe 1 week, we've decided to send nurses, very experienced nurses, into healthcare facilities to do prolonged mentorship.
So our mentorship is based mostly in public facilities, and these public facilities are where the poorest of women attend and go to deliver from, and there are very high volumes of deliveries. So majorly we do what we call in-facility coaching for the nurses, because the nurses cannot afford time to go and get more skills outside the facility. We also tend to look forward on CMEs, and we make sure that they are able to understand what they are supposed to do through learning in the facilities. We also do simulated emergency drills, whereby the nurses act as though they are the patient, as though they are the facilitator, as though they are the first provider and second provider, and they are able to catch up with what they are supposed to do. So actually, the emphasizing thing that we do is on respective maternity care, because some of these patients are treated with no respect. Sometimes they're even told to clean their own mess and to carry their own babies to the beds. So it's actually a bit disgusting. So we tend to shift the nurses from that into giving quality and respective maternity care.
So over time, our mission has changed a little bit, or the model of mentorship has changed a little bit. So we used to send one Jacaranda mentor into a public facility, and she was the one that was mentoring all of the nurses. What we found was that although that model was effective, it didn't necessarily have the impact that we wanted. So our model has changed so that our Jacaranda nurse mentors now act as like a trainer of trainer models. They go into public facilities, identify nurses there who will act as their own mentors for the rest of their nurses. So we have a Jacaranda mentor who then trains many other mentors within public facilities, and then they act as their own mentors for all of the other frontline providers. And we feel that this has greater impact, but also a wider chance for sustainability. So the Nurse Mentor Training Center, which is what Dining for Women has graciously funded, is where we are going to create all of these really experienced, highly effective Jacaranda nurse mentors. So we need a space where we can train them for approximately 6 to 8 weeks so that they can be really equipped to be able to go and train others how to mentor. So we don't necessarily need just the emergency obstetric training, but also, like Jane was mentioning, respectful maternity care, birth crisis, quality improvement projects, monitoring and evaluation. We need to teach them how to do all of these things so that they can teach others how to do all of these things.
So this is an example of what happens in the public facilities where we do the mentorship, and we are able to go through with the nurses on most of the complications that happen, and they are able to practice so that by the time it comes, they encounter the complication, they are able and their skills are up to date on ensuring that they're able to do it very well. So we have shoulder dystocia, and we also have neonatal resuscitation, which are some of the major complications that occur in the facilities.
And we know that our mentorship project works. We've done lots of data collection. So we currently have 5 fully trained Jacaranda mentors that are deployed in 4 different counties in Kenya. These mentors have mentored over 50 in-facility mentors who have mentored over 1,500 frontline nurses who have affected over 75,000 lives, both women and babies. And as we study these programs and the facilities where we do have mentors, we've seen a 20% reduction in maternal complications in those facilities. So now that we know that it works, we're really ready to expand our program and to make more of these super Jacaranda nurse mentors that can go and train others how to mentor well.
So this is ideally what happens in a simulation center. We have just spared us a small room whereby we train most of all the mentors that join us as mentors, and they are able to go through all the simulations, all the CMEs, and all that is required for them to be super mentors. So this is what happens in a simulation room. Our simulation room is so small, and we are shown how a breech delivery is being done from the beginning up to the end. So these are the super mentors that are in Jacaranda Health, and they are training new mentors so that by the time they go to the public facility, they are well equipped with their skills.
So we have identified a space for the training center already, but we have lots of priorities and goals for 2020. The first is that we really want to expand the current space. As Jane said, it's quite small and compact, and we really want to incorporate a fully functional training center into Jacaranda Health. As we've said previously, we have been asked by more counties to do mentorship. And so with new counties, we need new mentors. And so we really want to spend our time in 2020 increasing the number of Jacaranda Health mentors as we expound to these new counties. We have now fully written up the curriculum that we provide in the training program, and we have submitted it to the Nursing Council of Kenya for accreditation. And we really want to focus on specialized skills. So skills like ultrasound or breastfeeding instruction, things like that, so that we can invite providers to come and do specialized skills training beyond just our immediate EMOG package.
So once again, thank you so much for giving us this chance. We look forward as Jacaranda Health to get your donation in supporting this. Thank you so much.
Oh, thank you for such a wonderful presentation. So my first question to both of you is, can you paint a picture of who your clients are? Jacaranda Health is working in government hospitals. You're working in public hospitals where most of your clients are paying next to nothing, I imagine, for these services. Women are typically resilient, but tell us who these women are.
So these women are very poor women who tend to go to the public facility because they don't have anything to pay for their bills. So you find that these facilities have a lot of women. You find that they share a bed, like 3 or 4 mothers sharing a bed with their babies. So you find that one nurse is catering for several patients, like 5 patients for one nurse. between 5 and 60 patients for one nurse. So it becomes very hard for this nurse to concentrate on other things other than to just do the basic things that she can. So in our this chance that we have, we are able to teach them on giving the best quality care and to promote respective maternity care, even though they have very large volumes of patients to cater for.
Absolutely. Jane, you yourself have worked in refugee camps. I can imagine the level of care that all of you are giving in this project. But if the mother has not necessarily connected with your institution in her prenatal period, right? You're kind of just dealing with the information she has on her card and you're kind of going with it, right? So you want to tell us a scenario that might show up and how all of you cope?
Yes, it happens that most of the time we go to the facility, you have very little information about the patient. So you have to dig deep for you to get to understand what really this mother has gone through. And therefore, we have to be respectful. Sometimes the mothers are not very ready to give you the full information. So you really have to be patient with them. And that is what we are training these nurses in the public facilities, who are sometimes not very patient enough with them.
And I just to add on to what Jane said, I think because of that, because you have such little background about most of your patients, I would say 99% of the patients that walk in either haven't had prenatal care at all or they haven't had prenatal care at that facility, you really do have to be equipped to handle anything. So whereas in the States, you would never have a woman come in who didn't know she had twins. That happens all the time here. You would never have a woman come in who didn't know she had a breech baby, but that happens all the time here. So in the States, it may be a little bit less important to know exactly how to do a breech delivery. Here, it's very important because women walk into hospitals every day, they're fully dilated, and it's a breech baby. So as a nurse, you have to know how to deal with those complications because they're just so prevalent here.
Wow, this is so interesting. The level of care that you're giving and the resilience all of you are showing in these kinds of conditions is absolutely fabulous. So if one of you would address one of these issues that is somewhat cultural about the respect for maternal care, so that our members understand how you're trying to change the culture too, in addition to raising the training and the skills.
Yeah, I feel like that's one of the most important components of our mentorship program. So everything that we do, the skills training, the lectures, the drills, everything like that has a foundation of respectful maternity care. It is definitely changing here, but there is a history of disrespect and abuse amongst all hospitals, especially in the maternity ward here. And we've heard countless stories of women being slapped during labor, hit during labor, told that they're not doing a good enough job pushing. They are not allowed to have any birth companion, including the father, with them during the delivery. These kinds of things happen. I mean, I can't even tell you how much they happen. It's all the time in every single facility. And so when the nurses come in, they're really trying to change the culture so that it is a culture of respect. And sometimes it's met with a little bit of resistance, but every day they keep pushing the boundary a little bit more and trying to say, like, this is not just a patient, but a person. They really try and push that boundary and try and change the needle to respectful maternity care with every single encounter with the patient. It's really amazing. I mean, you can talk a little bit more about the actual stories, but they're terrible.
Well, as we wrap up, would one of you want to take a stab at what Jacaranda Health wants to do next? Following up on medical care after the baby's been born and kind of following up on the mother, ensuring breastfeeding, all that stuff in the time we have.
Yeah. So there's lots of challenges still to face in Kenya. So I think that we will try and address a lot of those. We have so far been addressing facility level challenges, and we haven't really delved into systemic level challenges. So referral challenges, ambulance challenges, staffing shortage. There's a lot of nurse rotation that happens. So one of the things that we have found is that we will go in and equip all of these nurses, and then they're rotated to another facility. And so, all of the work that we've done, we kind of feel like is lost. Those kinds of challenges that we really want to work with the government. So far, we've worked with the sub-counties and the county level government, but we haven't necessarily broached working with the Kenya Ministry of Health. And that's kind of where we want to go next, so that we can really start to incorporate mentorship and all of the challenges that go along with that, systemic and facility, and try and really affect on a large scale the quality of maternal and newborn healthcare in Kenya.
Absolutely. So Jane and Sarah, thank you for being these first line of professionals for these mothers and children. Dining for Women is right behind you, and we absolutely respect the work that you do in bringing dignity to motherhood, bringing dignity to birth, and all of those things. Our very, very best wishes to you.
Thank you so much, for your support and for everything.
Thank you.
Great.